Thank, and hi everyone. Thanks for being here from all over. That's super exciting. Maybe a little longer than 20 minutes because I added stuff after I told Carolyn it was 20 minutes.
Awesome.
But hopefully it's a fun discussion. Um, Disclosure, I sort of oriented this more like folks who know a little of the basics of CBIT. I'll still go through those. But our goal and hope here was really to share a little bit more about how our thinking has evolved as a group about CBIT, specifically this idea of doing it in a really patient-centered way. So there is a published CBIT manual. So when I was a grad student way back when, gosh, over 20 years ago now, I was a research assistant working on the studies that were testing the original CBIT manual. So it's been a while, and I want to highlight that. So this was the early 2000s that that manual was being tested and developed. And a lot of things have changed in terms of, research directions, how we think about patient care, how we think about things like neurodiversity, identity, and for my own development as a clinical researcher, just, interacting with new generations of patients, our patient advisory board that we have at Mintic and other work we've done with groups like TTAG, Tourette Ticks and Tourette's around the globe, Tourette Association has sort of just shifted some things for us in how we kind of think about CBIT away from this provider-centered care model toward what is called more of a patient-centered care model. And this is like a Gemini generated image, so it's imperfect, but I thought it was sort of a cute depiction of kind of these two models. And so this is an idea in medicine that traditionally we have developed treatments from more of this provider-centered care model. So the kind of idea that the provider is the expert who gives the diagnosis, prescribes a treatment plan, and then it's the patient's job to adhere to that plan. And this newer model of patient-centered care is across a lot of areas of medicine. And the idea is thinking more in terms of like a provider and patient in kind of a partnership of mutual discovery about, how do we both work together to understand what your goals are, make sure that me as a clinician is tailoring my work to align with your goals, for us to collaborate on creating a treatment plan and on implementing that. And so this kind of leads to our what I'm calling the Mintic Labs take, which is really grounded in this philosophy of patient-centered treatment and sort of re-envisioning what we think of CBIT as. And so traditionally, CBIT is really thought of as this is a management strategy to with the ultimate goal of reducing tics. It's about reduction of symptoms. And we're pivoting a little away from that in this model and thinking of it more as a set of skills and strategies that can help people clarify what their individual goals are and their values around their identity as someone with tics. A lot of people have a lot of really positive identity relationships and experiences related to their tics. So, how do we sort of think about that with this idea of also reducing symptoms? Really thinking about education as a means to self-understanding. I'll talk more about all of these. Thinking about how to manage tic triggers, how to manage tics the patient finds bothersome on their own terms. And then how to support those around the person with tics to really center that person instead of the tics. And we call this tic neutrality. So really treating a person as who they are rather than reacting to what their tics are doing. And so we really think of this idea of there are these core components of CBIT that we want to tailor to a person's own goals and that we are deciding success in relation to those goals. So the first step we think a lot about is this, how do we clarify goals and values and get on the same page about what it is that patients want when they come to us for CBIT? This was a paper that we just published in December, led by Emily Kuhn in our lab. And she was really interested in this question of like, why do people come to get CBIT? And all of the clinical research studies and trials that have been done, we measure CBIT based on its success and medications, all these treatments. We say, are they successful? And the way we measure it is based on tick reduction. And we have a clinical questionnaire. It's administered by a clinician who does sort of an interview and then decides how severe someone's ticks are. And then based on changes in that, the clinician decides if the treatment worked. And Emily sort of flipped this and said, well, what if that's not why people want CBIT? And so she looked at these data from a study in our lab. This was 50 12 to 21-year-olds who came in for a study involving CBIT. And as part of the study, they identified the reasons we call them tick hassles, like reasons their ticks were getting in the way that motivated them to do treatment. And we really didn't see many people at all talk about, I want my ticks to go down. What we saw were these things like my ticks get in the way of social activities, or they hurt. They make me really tense. I have emotions about being a person with tics. The tics get in the way of certain tasks I want to do, like getting dressed or being able to write or talk to other people. Activity restriction, like I really would like to go to the movies, but it's hard to with my tics, or I'm trying to fall asleep and my tics are getting in the way. And so I highlight that to say that, the reasons that folks are coming to us for treatment are really different. So an important step we think about in CBIT is getting on the same page about what that is. And here's just sort of a smattering of some questions that we use to sort of help orient this question. And it can also really be helpful for patients. A lot of them don't know why they're coming to us. So in our outpatient clinic, our process is that we see people for 2 initial visits just to understand what their goals and values are and then decide if CBIT is the right treatment. A lot of people, thankfully, from neurologists are getting referred to it, but they're like, I don't know, someone said I was supposed to do this treatment, so here I am. So we want to really understand what their goals are and if this is the right match. So thinking about things like, what do you want right now? What are your goals for the future? What is your identity around having tics? What would change if your tics changed? Are there positives and negatives to that? Also emphasizing that CBIT isn't a cure. We know it won't disappear all the symptoms. And what are the reactions that someone has to knowing that? Is that frustrating? Is that okay? What would success look like? Are there specific tics you most want to work on? So sometimes folks come in and they're like, it's honestly just this one neck tic. And if that goes away, I'll have less pain, and that's a success to me. Great. It's good to be on the same page. And then this last question is pretty important about what do loved ones hope for? Especially we work with a lot of kids and adolescents, and parents and kids aren't always on the same page. So trying to understand what are the person with tics, what are their goals? What are family members' goals, and where they're different, can treatment sort of help come to some like shared understanding of what is most helpful for the person with tics? Oops. And then going to this question of, is CBIT the right answer? And I saw some of the questions that came in ahead of time, thank you for sending those, were like, is CBIT good for this or that or this or that? And it's really important. We tell this to patients, like CBIT is for tics. It's very specific to that. And we know from research it can reduce tic severity, urges, improve someone's sense of control over their tics, improve impairment related to their tics. But we also know from research that the benefits don't spread to other challenges. We don't see CBIT change things like anxiety or depression or ADHD. It doesn't touch things like self-disclosure of your diagnosis, identity, if there are broad family functioning challenges. There were some questions about functional neurological disorder, functional tic-like behaviors, which are a sort of more recently recognized phenomenon. And FND is its own diagnosis. It's not just you don't have something we understand, it has its own positive symptoms. And this research is in its infancy, but what I can say, this is integrating research and like what we've seen in clinic with a lot of patients who have FND and tics, is that some of the principles overlap, but it's not the same thing. And so it does have to be done a little bit differently. So just because we have CBIT, right, we have a hammer, not everything is a nail, and being really careful about when we apply it is in the patient's best interest. There were also questions about like, when do you do CBIT? And this is, I think, again, a really patient-centered question. And what we try to do at the front end is really educate about what CBIT takes. And the way I explain this is that, CBIT is really built as a self-imposed behavior strategy. What does that mean? It means that I, as the person, have to be aware of when my symptoms are happening, make a decision about to use a skill, and then practice that over and over. What does that take? Age is one, and age is really more a proxy for like cognitive abilities and developmental maturity. So if I'm a young kid and I have ADHD and I'm not super aware of my body and my internal sensations and my cues, the CBIT's going to be a setup. It's going to be too hard. So I like to tell parents, CBIT is the kind of thing where I'm going to ask your child to sit down and say, all right, tell me how many times you think you blinked in the last minute. And then now I want you to notice when you're going to blink and try to do something differently. That's pretty tough. And we don't want to ask them to do something that's beyond their capacity. So I think about it as it's the right match if it's within capacity. If there's motivation, distress. So we really emphasize, I kind of give the like coach speech at the beginning of like, look, CBIT can be really helpful, but it's only helpful if you do the work. It's kind of like you're coming to me to learn a new sport or learn a new instrument. If all you do is come to your lesson and do it here, it's not going to help. If you come here and then you're able to commit to practicing it a lot in between, it's going to help. So, is that a commitment that you feel like you can make right now? And normalizing that it's okay to say no, because I would rather have kids say, that sounds too hard right now, or it's the beginning of my new football season and I just can't do that. Great, that's okay. Let's think about when timing might be right or what would tell you that the timing is right. Evaluating success. So, like I said, we usually measure success in clinical research based on these clinician ratings of tick severity. But what I just sort of want to point out here is we are starting to use more patient-centered measures, both in our research and in clinic, to really make sure that we're evaluating success based on the patient's own goals. So a nice one that we're using is the top problems assessment. It's sort of an interview that helps you identify the top three reasons that you want to that you're hoping to get help, and it really frames them within what's in your control. So, for example, we try to help kids identify what they can control about their ticks versus others. So, if they say, "Well, I want to not be bullied for my ticks," we want to try to break that down into like, what do you have control over? So maybe it's I want to be able to assertively explain my tics, or I want to be able to talk to my teacher if I'm having a challenge with someone, like really couching it in what is empowering, what is possible for them. And also thinking about more of these impact quality of life measures. I guess this is more for the researchers among us. Um, so the next part of CBIT is always psychoeducation, but we really think about it in terms of empowerment. I love school, I love education, and I think one of the things it does is it empowers us to have better understanding of ourselves and the world around us. And a lot of families come to us and they're kind of scared of the word Tourette. And us being really factual and aligning with them that like knowledge is power can be really helpful. So we try to be really factual. Tourette is a medical term. This is what it means. This is what it doesn't mean. And we're really fans of making sure children know what their diagnosis is. Kids are very good at making up stories when people don't explain to them the truth. And oftentimes those stories are scarier than the truth. And so we really try to normalize that, if you're having reactions, there is like stigma around this word, but here's what it really means. And knowing what your diagnosis is helps you understand some of your own strengths, some of your own challenges. It helps give us a roadmap for treatment. So, this idea that, like, now that I know your diagnosis, there are guidelines I can follow to help you, and things that we know from research that are helpful for people with your diagnosis. And it also helps people connect to communities. So I know we have some T-tag folks here. There are groups of people just like you, and they join together because they have this shared diagnosis, and now you can, that might be a community that would be helpful for you to be a part of. CBIT, we also teach the biology of ticks. In our approach, what we're really focused on is making sure that patients know that ticks are caused by biological differences, influenced by the environment, and involuntary. So I'm sure some of you have had this experience on the call, but there's a lot of, it can be confusing when we talk about behavior for people to understand that tics are involuntary, especially because they can be reactive to different situations. And so, what we really do here is lean into helping patients and families understand that this is a medical condition that's influenced by situational factors and that it's not unique in that way. So, thinking about things like asthma or diabetes, where we say, you know, there are situations that can trigger some of those symptoms, like eating certain foods, or if you have asthma, like exercising in the cold. Knowing those things can help you manage your symptoms better. There are tools like skills and medication that can be helpful. But importantly, if someone with asthma has an asthma attack, we understand that it's not their fault. We're not blaming them. We're not asking them, why are you doing that? Can you just stop doing that? It's a medical experience that they're having. And so thinking instead of, okay, when someone's having a lot of tics, they're not doing it on purpose. We can think instead, okay, what can we do to help support them to manage their symptoms, just like we would someone with asthma. We also like to just emphasize that there's good understanding of tics in the medical field. I still hear so much like, people just don't know anything about the brain, or no one really understands what's going on in Tourette's. And actually, we do. We have a really good understanding. Of course, there's more to learn. But I think that's really reassuring to people. I know when I'm a patient, I don't want to walk into an office and think that my clinician is like working in this vague mystical area where nobody knows anything, right? And us saying, no, we get the biology is very reassuring. And also the brain is cool. So we have, I'm happy to share this slide with anyone, picture. But we have some of these sort of cartoons and ways we work through helping kids really understand these are the brain systems that cause tics, and it's like too much activity in this movement circuit and not enough activity in this control circuit. So it's like too much gas and a squeaky brake, and then your emotions are connected to that. And we'll use like the real brain terms, like this is your basal ganglia, this is your thalamus. We'll draw it out on there. And again, this is all knowledge that's really empowering and helps kids know, okay, this is what's going on in my body. This is my condition. And there are strategies for it. Comorbidities. We want to emphasize here that 80% of people have another co-occurring condition. What I like to explain after you've gone through brain stuff is really helping people understand that these brain circuits are the same circuits that are involved in the most common comorbidities. So ADHD, OCD, it's the exact same brain systems. And so that can be really empowering to tell people like, um, we have these different medical diagnoses for them because they were these terms were developed before we knew as much about the brain. But what we know now is that these are all really related to each other. So it's kind of like one thing. It's not like you have four diagnoses. It's like one or two things going on, and we understand what they are. And that can be really reassuring. We also emphasize that some of these conditions are not a given. So things like anxiety and depression, we know a lot of people with tics develop those later in life, probably because of unsupportive environments and negative experiences around their tics, like discrimination or bullying or feeling not accepted by loved ones. And so we can again really frame this that knowing this, we can really make sure we're thinking about your support systems and what is available to you to feel supported, because that will help you be resilient against developing some of these things. I also just really like the iceberg picture because we often, there's, kids in clinic where we just put it in front of them and seeing this like printed and made by someone else, and they're like, oh, I have this one too, and I have this. Oh, you know what that is? This is a thing. It's not just me. It's not that I'm, lazy or sloppy on my homework. Maybe I have ADHD. And so it can just be a really nice way for kids to recognize what's going on for them. I'm saying kids a lot because we see kids in my clinic, but a lot of this applies to adults too. So for those of you working with adults, hope it's still helpful. The next step in CBIT is what's called functional assessment and functional intervention. We call this identifying and adjusting tick triggers. And so this is the idea that we know that ticks are influenced by activities, environments, situations, and that ticks can be more likely to happen with these things, and they can also be reinforced by these things. So the consequences or things that happen after a tick can kind of stamp that learning into the brain because of dopamine. So dopamine is really active in the brain when you have ticks. And then if a tick happens and there's a consequence that's helpful to you, the brain actually learns to keep doing the tick in that situation. And a lot of folks, they don't want to be more aware of their tics at first. They're like, they bother me. I want to distract myself from them. I don't want to think about them. And I kind of think of this as like any sort of physical health or mental health pattern we have, like knowing our own triggers and our own patterns often is really empowering for helping us know how to adapt things to our strengths, right? We were just talking about this in our lab, like about writing because we have to do writing and sort of saying to everyone, okay, what situations are best for you? Like, what time of day do you write best? Do you like it when you're listening to music or not? Do you want it to be at home or at work? Knowing those things actually sets somebody up for being more successful in meeting their goal of writing. And I kind of think tics follow a similar train of logic. So, how do we do this? Importantly, we don't want to do things to people with tics. We don't want to just change their environment without their agreement to it. But that can be hard because some of these things, sometimes tics lead to outcomes that are positive. So, for example, we sometimes see kids where like the worse their tics are, the more attention and cuddling and snuggling they get from parents. And so we don't want to remove that. We want to think about what's an alternate tick neutral way to get access to all those good parental attention things. So I have here, you'll see, so we want to modify situations to minimize the impact of triggers without increasing avoidance or reducing participation in healthy, valued activities. What does that part mean? Um, a lot of accommodations that I see for tics are things like they leave class when their tics are bad. Okay, that's going to probably make their tics happen more when stuff is hard in class. And also now we've just removed that kid's ability to learn in the classroom, like whatever was happening, or they're missing out on something. Kids are noticing that they're gone. So how do we think about it instead as given the limitations of tics, so there are some, how do we adapt it to make it more possible or find a good replacement? So we always want to make sure that when someone has tics, they're still getting access to all of the important things that they need, but we might just have to tweak it to make it possible for them. Analogies to this that can be helpful are, I recently had knee surgery, so I thought about this accommodation adaptation a lot, and I couldn't use stairs for several months, right? And so it wasn't that, and my office is on the second floor of a building. I didn't stop going to work because it was hard to do. I used the elevator because that accommodation, that adaptation was there for me. And so, sort of thinking about tics that way of how do we change this situation to help this person participate in what they need and want to do? So this step in CBIT is called competing response training. We call it tick management skills. So you'll see some of the wording too. We've thought about a lot with patient-centeredness. Um, Tick management skills. The focus here is on ticks the person wants to work on. It doesn't have to be all ticks. This is kind of confusing. If you look at the original manual, it sort of implies that to successfully treat ticks, you must deal with all of them. You must treat all of them. When new ones come up, you have to come up with a new skill. But we've sort of leaned more into this idea that, like, ticks themselves are not inherently good or bad. The impact they have on the person is what we want to help with. So if a tick is hurting, we want to help them. Someone's like, yeah, I blink a lot, doesn't bother me, doesn't get in the way. We don't have to do anything about that. Really letting the person lead with what they are wanting help with, and that it's really grounded in impairment. So we just work on what they want to work on. And that we really think of these tools as skills to increase a sense of control. So getting, better at noticing ticks and then doing tick blockers. So I won't go into that too much, but it's this idea in CBIT of doing a alternate behavior with your body. And what that's doing is helping strengthen the brain brake. So making the brain more able to put the brake on movement messages that come through. The other thing we think a lot about is practicing those skills in situations that are important to the patient. So, anytime we practice a skill in a situation, our brain is pairing that skill with the situation. Conditioning, classical conditioning. Some of you might know Pavlov's dogs, right? And so our therapy room is kind of arbitrary. Like people aren't coming back there and hanging out and asking people to go on dates or taking tests in our therapy room. And so we really try to think about how do we help make sure that these skills are there for you when you want them in the situations you want them in. So thinking for the clinicians in the group of how do you in the CBIT manual, it says like, oh, do these things to make the ticks happen, like put yourself in situations to make ticks happen so you can practice. And I would say, no, how about we put ourselves in situations that are meaningful to us and work on practicing them because then our still skills will be available to us when we're in those important situations. Um, Finally, we have social support. This is the last step in CBIT where we think about how others can support the person with tics. So the first patient-centered question that's important is who is the support? We can't just assume because someone's a child that a parent is supportive or that they see them that way. And so it might be a friend, it might be a teacher, it might be a coach, it might be a cousin. So letting the patient identify who that person is and then helping them negotiate specific ways they can be helpful. The main piece we focus on here is a tick neutral environment. Um, and so the idea here is, like I mentioned earlier, that ticks can increase with attention because of that dopamine hit that comes with like warm and fuzzies. And so we want to really just help make sure that people are still getting the attention they need. That's a basic human need to feel loved and attention and that we don't feel bad things. So we say, okay, how do we make sure you get all of those needs met that it doesn't depend on something about your ticks. So instead of, oh, you had a hard tick day today, let's have some extra movie time. Saying, let's think about when we can do some extra movie time together because I like spending that time with you, right? So it becomes less connected to the ticks themselves. Um, and then, we can work with the patient and family to sort of think about, where is it appropriate for you as a support person to air your grievances or frustrations or challenges? um, and how can you sort of be maintaining appropriate expectations for a kid. So my goal here is often just to say, okay, what would you want of your child or hope for them to do if tics weren't in the picture? Okay, now let's think about how we help them do that. We might have to adjust, but we still want your kid to be able to like go to soccer or play this instrument. We're not going to drop it off because of tics. Let's just think about how to adapt it so that they can still do what matters to them. And then there are lots of other topics that we find ourselves integrating into CBIT a lot that aren't really in the manual, but we feel like come out of necessity of really doing CBIT from this patient-centered way because most people's goals are not just reducing their tics. And so the ones that often come up for us are around the sort of navigating specific social situations. So kind of how to think about tics and skills as and like tick blockers as part of a toolkit with social situations. So For example, like there might be different strategies if you're trying to navigate your tics in a job interview versus at when you're talking in front of everyone at school versus when you're just chilling with your friends, and sort of giving patients the permission, if you will, to say like you get to choose when these tools are important to you and when they're not, and it's just up to you. You don't have to be using them all the time for them to be there for you. Self-disclosure comes up a lot for us. We can maybe, Mayella can throw it in the chat or we can send it out later, but Young in our lab made a really nice video about this. So we talk a lot with kids about these sort of zones of disclosure and the idea that like the green zone is people who are close to you and why it's helpful to share with them your diagnosis. And then, out to the red zone of like, you don't have to tell strangers. It's none of their business. You get to choose who you tell. School accommodations, medication. There was a question about that ahead of the webinar. Um, medications can be helpful. And the piece that we think about is again, how do we empower patients to get knowledge about that? So I'm often finding myself as a psychologist saying things like, if you're having any questions at all in your head about medications, thanks, Mela, you can make an appointment with a neurologist or psychiatrist and you don't have to walk out with a prescription. And in fact, the good ones you won't. Like it can just be information gathering. And just knowing what your options are can just feel reassuring. So you kind of know now or in the future. Um, the other thing, like I said, CBIT is really specific to tics. So we aren't really focusing on comorbidities in CBIT specifically. So sometimes you do have to pull in if you're a clinician and you're comfortable doing these other interventions, like pulling in other evidence-based treatments might have to happen to support your patient's goals. Or if those aren't in your practice, knowing like when to and who to refer to is also something, we do that a lot in our clinic. We're a pretty specialty clinic of OCD and tics. And so we see a lot of kids who have maybe their tics are significant, but their depression is much more impairing. And we're saying, okay, the best way to support you right now is for you to get some care around your depression, and then we'll be here to help with your tics when that feels like it's more managed. And then family functioning, as I mentioned, CBIT, we talk about tic neutrality and all these things, but sometimes there's just a lot more going on for families, and family therapy is something we might be encouraging families to do. So all that being said, we are a research lab, and part of what we do is we're constantly thinking about CBIT and its limitations and how to improve it. And hopefully these are some suggestions, but there's still a lot of room for improvement. We know that 40 to 60% of participants in the original trials didn't benefit from CBIT in terms of tic reduction. So we have a lot of questions as a MinTic lab about like who is most likely to, some of the questions you even asked in the chat, so I was delighted to see them. Like when are medications helpful? When are they not? What age is good to do CBIT? Like we don't know all the answers, and these are things we're trying to understand better through these various projects that we have in the lab. I won't harp on them, but um, I'm guessing you know about us since you're here, but we are always happy to stay in communication. We have research study opportunities for treatment, non-treatment. We have a clinic for people up to 21 years old. That's just an outpatient clinic. And we can also help point you in the right direction if we're not able to meet your needs right now. So with that, I will stop. We can stop the recording.